Good afternoon, everyone, and welcome to the 2019 Harmony webinar series. My name is Christy Weeks, and I am the Business Development Coordinator for Harmony. Today's presentation, Buprenorphine Friend or Foe, will be facilitated by two of Harmony's own, Chief Clinical Officer Dr. Annie Peters and Medical Director Dr. Chris Reevely. For those of you who are new to Harmony, we are nestled on a 43-acre campus in the Rocky Mountains, just outside of Estes Park, Colorado. Our Colorado residential rehab offers comprehensive treatment for adults and their family members. Who is Harmony Foundation? Our why factor: we believe that long-term recovery from alcohol and other drugs is possible. As a place between two worlds, our location in the Rockies provides a safe and quiet respite from the pain of addiction. With 50 years of treating addiction, we have fostered a generation of long-term recovery who supports our clients and families for a lifetime. Harmony staff at all levels of the organization work together to create a community of recovery support that is long-lasting. Who we are? We are a 70-bed residential treatment program, again located at the base of the Rocky Mountain National Park. We offer an evidence-based 12-step program that is gender responsive. To learn more about Harmony Foundation, we invite you to visit us at www.harmonyfoundationinc.com or contact our admissions staff at 866-686-7867. As we move through the presentation today, there are just a few housekeeping items to keep in mind. You will be receiving an email within an hour after the presentation. Please be sure to complete the online evaluation. You must be actively engaged in the presentation for at least 45 minutes in order to receive a certificate. We use a system that tracks how long people are engaged in the program, so anything less than that would not qualify for a certificate through NADAC for CEUs. However, if for some reason you need to jump off early, we can provide you with a certificate of attendance. You will receive a certificate by Friday. If you do not, please let me know, and you can reach me, Christy Weeks, at cweeks@harmonyfoundationinc.com. And I will say this now, and I'll repeat it at the end as well. If you are interested in receiving the slide deck and or the audio recording, you can email me at that same email that's listed on the screen, and I will be happy to share those with you. I'd like to take a moment to introduce you to our presenters. First up, we've got Dr. Annie Peters. She is our Chief Clinical Officer. Dr. Peters is a 2004 alum of Harmony Foundation. In 2008, she completed her PhD in clinical psychology from the University of Colorado, Boulder. She began her addiction treatment career at Hazel and Betty Ford Foundation as a staff psychologist in 2006, and then as a professor in their Graduate School of Addiction Studies. She joined the Harmony team in 2014 as Chief Clinical Officer. Joining her today is Dr. Chris Reevely. He's our Medical Director. Dr. Reevely attended the University of Colorado Boulder with a BA Psychology in 1977 and Dartmouth Medical School. After completing residency training at the University of Rochester, he worked in the field of anesthesiology until 2012. He completed the fellowship in addiction medicine at the Rushford Center in Middleton, Connecticut, and began as a medical director at Harmony in 2016. Dr. Reevely has a particular interest in refining and focusing medication-assisted treatment for those with addiction, as well as evolving non-traditional integrated role of medical providers in the residential treatment team. So, now that I've introduced our wonderful team, I would like to let you know that we will be fielding questions and answering them at the end of the presentation. So in the little chat box or in the question section, you may type those. Those are on the right-hand side of your screen. And at this time, I am going to turn everything over to Dr. Peters and Dr. Reevely.
All right. Hello, everybody. I'm very excited to be here. I'm going to share my screen, what I'm looking at. So this is Annie Peters, and I'm really excited to present with Dr. Reevely on this topic. We've worked very closely together at Harmony Foundation over the past couple of years to really look at our MAT practices and integrate them into our treatment program. Being that we're the oldest treatment center in Colorado, and we want to, when we move forward with something that's an evidence-based practice, we want to make sure that we do it very thoughtfully. So my experience with this, I've been in the addiction treatment field for about 13 years now, and I'm also a person in long-term recoveries. As Christy mentioned, I'm an alum of Harmony Foundation from 15 years ago. My previous job before Harmony was at Hazel and Betty Ford, and it was right around the time that they were starting their Core 12 program, which is comprehensive opioid response in the 12 steps. So initially, being a person in recovery and working in the field, I was very skeptical about buprenorphine, which is what Core 12 was looking at using. And so I initially had that question, buprenorphine, is it a friend or a foe? And we wanted to keep this title because we wanted to say, why are we still thinking it's a potential foe when the evidence clearly supports the use of MAT and buprenorphine specifically? But there are some people in recovery, and there are some treatment providers that still are under the belief that you're not in recovery if you're on buprenorphine, or have other beliefs about buprenorphine that are challenging. So we want to really just address those head on. It's still a controversy, and we just want to be open about that. And so I am glad to be here. Before we start, Dr. Reevely, do you want to say anything about your interest in this topic?
Sure. Yeah, this is Chris Reevely. I'm the medical director at Harmony. I was an anesthesiologist. I did a retread, as we say in the medical profession, came back to Colorado, where I live, just a few miles from Harmony, and assumed the medical directorship here in 2015. And yeah, I would say that our knowledge about buprenorphine and on how to use it as a tool in acute detox, post-acute withdrawal, and long-term recovery is still very much a work in progress. And so that's why conversations like this are so important. So thank you all for being here, and we will try and get to all of your questions at the end. And so off we go.
Excellent. Thank you, Dr. Reevely. All right. So these are the learning objectives that we have for this presentation. So looking at a case study, which is Harmony Foundation, of how we expanded our MAT services into our program, which is traditionally 12-step and abstinence-based. Then Dr. Reevely is going to talk more about MAT, discussing the pharmacologic properties of buprenorphine and how it's used well. And then I'm going to talk a little bit more about the clinical components of how to build really a successful, comprehensive, wraparound recovery program that uses buprenorphine as well as the T in MAT and the R in MAR. Sometimes people call it medication-assisted recovery. How to really integrate those two together to really meet individual needs. So how we built HOPE. So HOPE is the Harmony Opioid Programming Experience. We decided that was a good acronym, and so we call our program the HOPE program, or the HOPE track at Harmony. And this was the timeline for how we created this. I'm moving my thing there, how we created this program. So we really wanted to do this the right way, as I mentioned earlier. And so first we looked at our data. We looked at, of course, the national data and national research on MAT and buprenorphine, and we really wanted to look at our own data too. So we did a reach-in and looked at our outcomes. We do outcome surveys every other year, so with Omni Institute, and we asked Omni to pull out our outcomes for clients with opioid use disorders. And for the sample we had, the sample size was fairly small, but we did see a difference that our outcomes were not as good for clients with opioid use disorders. And we really feel strongly about having good outcomes and being able to be open and transparent about that. And our typical finding is that in a year, 1 year out from treatment, overall, our clients, 74% of them have been clean and sober for the past month, which is wonderful. But they weren't as good, our outcomes weren't as good for clients with opioid use disorders. And probably most concerning to us was that our against staff advice discharge rate among clients with opioid use disorders was actually 4 times higher. And I think it's important just to call that out from the beginning, that we realized this wasn't just a need, a national need and a national crisis. This was something we were seeing in our own treatment center as an area in which we needed to improve. So we got input from everyone who we believed needed to be involved. So staff, families, clients, reference. We did a survey I'm going to talk about in a minute among our staff and stakeholders. We wanted to look at other programs, like I mentioned, the Core 12 program at Hazen and Betty Ford. We wanted to look at other programs that were using buprenorphine in ways that we believed were consistent with our philosophy. We wanted to examine the MAT practice guidelines and make sure we were following what is evidence-based. We definitely wanted to involve Narcan and educating an education component for staff and families and clients. We wanted to make sure that our mission at Harmony is to provide the foundation for long-term recovery. So to do that, we know that Harmony is just the beginning, just a foundation. And we knew that we needed to provide people with connections to ongoing MAT and ongoing wraparound services and psychotherapy to continue their recovery. We wanted to develop client materials that were person-centered and helpful to the clients. We wanted to look at our outcomes and make sure we were practicing according to practice guidelines. And ultimately then, over a 3-year period, we launched HOPE. So that was the timeline, and this we thought was very interesting because in 2015, when we started this, Harmony having a 50-year history, we had staff who had been there. We've one staff person who's been there 35 years. So we wanted to see how our staff felt, and this is just one snapshot of the survey. We developed something we called the Suboxone survey, or the buprenorphine survey, and had a little bit of information about what it was and asked some questions to our staff. Here's one of the questions: people who are taking Suboxone long-term are not in recovery. And at that time, you can see that 38% of our staff agreed with that. There were 36% that disagreed, and there were 26% that don't know. And we really had some very, very varied comments. So you can see there, people are still under the influence of an opioid. So there was this perception of we're trading one addiction for another. And that was another question on the survey too. And then there were other comments: I don't think we get to decide what someone's recovery is. So this was really interesting because one of the things we realized is 26% of our staff don't know. So we really needed to provide some staff education. We did a lot of training. We actually did have a staff member or two who left Harmony during this period because of their disagreement with the philosophy. And there were a few referral sources. One I know in particular that just didn't send people anymore because they didn't agree with this philosophy. So we knew that we really just wanted to go into this very consciously. So this, there we go. So there's the survey. So then this is the program we built. So the Harmony Opioid Programming Experience components. We wanted to start everything with a comprehensive needs assessment. So look at a person from a biopsychosocial spiritual model. We wanted to make sure that we were providing people with addiction treatment, mental health counseling. We really have had a focus around integrated care and trying to help and support people, provide a foundation for recovery from all they're presenting with. And it's so common that people have co-occurring mental health disorders that we wanted to make sure we were providing that as well. One of the first things we did was developing an opioid support group, which is also now called HOPE Group. And that was one of the first things we did because we really wanted to provide a space for clients with opioid use disorders so they had a place to talk about how things were different for them as they perceived it and how treatment and recovery were different for them. We wanted to individualize how we did MAT, and Dr. Reevely is going to talk about that. We wanted to make sure we were addressing people's pain needs in using things that were non-addictive. We wanted to provide trauma-informed care because we know that people who use substances typically have a history of trauma, and we wanted to make sure that we were really safely approaching each person with safety and providing choice and supporting them in feeling like they were well supported throughout this process. We also wanted to provide a long-term recovery plan. So we didn't just want to provide a medication and a good luck. You know, we wanted to set this person up for success for long-term recovery. So extensive case management is a strong component of the HOPE program to get people really set up well, involved in their home community, wherever they're going, with the treatment services and the community that they really need to build their recovery. So now I'm going to turn this over to Dr. Reevely, who is going to talk about the MAT component, specifically around the medication buprenorphine, and I will turn it over to him.
Thank you very much. A couple of things to say about MAT right off the bat. First, arguably, medication-assisted treatment is a term that should and does, in my mind, include all medications that are used during detox, post-acute withdrawal syndrome times, and ongoing recovery. It may include mental health medications, it may include anti-craving meds, and a number of others, and general physical health meds. However, today, we are going to limit our discussion to the topic of buprenorphine, and that is certainly one of those. And finally, I would make sure that everyone, when you see the acronym MAT, that you emphasize the A. It stands for medication-assisted treatment, and I really am a strong believer in that. I don't think anyone who's working seriously in this field today regards buprenorphine or any other single drug as a panacea or a silver bullet. They're merely parts, components of a thorough recovery program, which will always and should always include peer support, counseling, changing people, places, and things, all the things that we have come to associate with a healthy lifestyle. So that first. And secondly, I would acknowledge that every one of us, including those in the room, have their own perspective. And so we're trying to, as Dr. Peters said, we're trying to present this in a way that acknowledges the spectrum of the folks and their attitudes toward buprenorphine. And so I hope your questions will reflect those, and I hope no one feels inhibited about asking the very most basic questions about the use of buprenorphine in medication-assisted treatment. So just some terminology to start off with. We have fallen into, and many people in the treatment business have fallen into, using the term drug as something that causes problems in people's lives and may lead to dependence and addiction. When I think of medications, I think of substances that mainly aim at improving the quality of life. Now, can medications, one medication be the same? Sure. Every time there's a new treatment developed for addiction that has a medication involved with it, that medication can be diverted and abused, and that may always be the case. So a typical client here at Harmony will be say a younger person, perhaps male, perhaps not. Let's say this person is around 26 years of age, may have used an opioid of some kind, often a prescribed opioid, or one of his friends or parents prescribed opioids at a very early age, say 14, maybe lost control of the use of those pills at a little bit later, and comes in with multiple overdoses, ER visits, residential treatments, and relapses. And often these people are using between 1 and 2 to 4 grams a day, IV frequently, but not always. Here in in the medical department, we are the first to see them for any sort of in-depth interview, and we try and do our histories and physicals within 24 hours after they arrive. And typically, mental status around that person, they'll be angry or utterly disinterested. which can be a reflection of the fact that they're feeling hopeless. They may have physical evidence of their use with tracks on their arms, sometimes in their necks, sometimes in their feet or legs, sometimes terrible loss of tissue from what they call muscling or trying to use their drug subcutaneously. So we offer people several options when they get here. They can, sit back and do what's called a traditional social detox, where we give them a warm, comfortable place to sit while they go through their own version of unmedicated withdrawal. Almost nobody chooses that. We can offer them a taper of, we can offer them comfort medications, calming meds for anxiety, sleep meds, anti-nausea meds for a few days while they go through it. And the third option is to use a tapering dose of buprenorphine, and that is usually not a linear taper. It starts out at a moderate dose and goes down steeply and then levels off like I think of it as landing the plane softly with a very small dose for the last 2 or 3 days. And then they may want to proceed on to an anti-craving medicine. Or in a few cases, it will become evident toward the end of the taper that they're just not going to tolerate this, and we may want to begin the conversation about doing ongoing buprenorphine for a period of time after discharge. So what's buprenorphine? It was first made in Britain in 1969. They were just looking for another pain medicine. And what they discovered quickly was that they would give people up to about 18, 20, 24 milligrams. And then after that, it didn't really have any more effect. And so it was the first among the identified so-called partial opioid agonists. And that's simply a chemical that sits on the opioid receptor. And in the case of buprenorphine, binds very powerfully to the receptor, more than any other opioid, and but does not have increasing response or effect with the more you give. So above about, say, 20, 24 milligrams, the effect graph levels out. It's a drug with a very long half-life, so it stays in your system for a long time, which is why we have to wait before starting on any other drugs that might interfere with that toward the end of treatment. And then it is used sublingually or transderm, and often and most commonly these days for short-term withdrawal. And should the person get to the point of using long-term maintenance, it's often a dose between 4 and 16 milligrams a day. Typically, people who come in having relapsed and having been in a maintenance program away from Harmony will come back and say, we all know that you don't get any more effect with buprenorphine above 16 milligrams, and I was being given 32 by my program, and I was just selling the other 16. And buprenorphine these days is used in inpatient, outpatient, emergency rooms sometimes, and is readily available on the street. And it's primarily used in a younger than average crowd in our experience here at Harmony. It's for long-term use, and whereas the National Institute for Drug Abuse initially recommended that methadone be used for 4 to 6 months, I see no reason to think of buprenorphine any differently than that. One of the most common mistakes that I see is people get out, they use buprenorphine for a month, think they're just great to go, they quit, and then they relapse or overdose on heroin or on some other opioid because in the meantime their tolerance for those other drugs has decreased. So this is just to reemphasize what I just said. If you look at all the full agonists, this graph, this is a dose-response, typical dose-response curve pharmacologically. If you look at the full agonist medications, such as morphine or methadone or oxycodone, the more you give, the more response you get. And you can talk about any response you want, be that euphoria or respiratory depression. And the endpoint of that full response graph line is death due to respiratory depression. On the other hand, if you look at buprenorphine, it goes up on the dose side of the scale on the x-axis to somewhere around 20, 24 milligrams. And then the more you give, you don't get any more response. And we think of that as an advantage. So we hope that the response that people get with a smallish dose, the smallest dose that is effective, will be enough to keep them out of the craving woods, keep them off the streets looking for drugs, and allow them to begin to do that other major part of recovery that we've already talked about. That's the role of buprenorphine. How long will people be prescribed it? I think when we look at intensity and duration of treatment, regardless of which anti-craving medication you're talking about, there will be a few people who will get into long-term recovery with very little treatment. So I know people who have had someone mention to them, for example, with alcohol, boy, you're drinking too much. I think you've got a problem. And I know people who've heard that once and quit drinking for the rest of their lives. On the other hand, most people fall under the big part of the bell-shaped curve. And then there are going to be a few people out there, way out there on the right end of the spectrum. During my fellowship, the methadone program I worked in, there was a guy who had been using methadone for 46 years. He had tried to taper off 12 times, had relapsed onto heroin every single time. And his family, who was initially very much opposed to the use of methadone, said, you know what? You got your life back, your respect back, your health back, your friends back, your job back. Just stay on it. And he did. So why do we use buprenorphine? Often when people first get here, and again, especially the younger than average clients, it's for harm reduction. We want to prevent them from running out the door here. If we can't keep them in the treatment facility for the first 3 days, we haven't done much for them. And if they leave, they're likely to use, in many cases, more when they relapse. And so we think of harm reduction as bottom line preventing death from overdose. And then, of course, harm reduction includes decreasing the incidence of infectious diseases such as HIV and hepatitis C. We would like to think that, and it has, I think, been proven to our satisfaction, that the use of buprenorphine encourages abstinence from their other drugs. They stay in long-term recovery more reliably. And at the end of a period of treatment with buprenorphine, be that 6 months or 4 years, it's important that they be tapered off of it very, very slowly to prevent relapse. And then we really do believe in abstinence being accompanied by psychosocial supports for our clients. And we work very hard at developing a good post-treatment discharge plan for them. How is buprenorphine usually used? It can, again, the different approaches to treatment, they can be unmedicated, they can use non-opioid medications, comfort meds, or they can do their treatment over a period of days. And usually our buprenorphine taper to help people separate from their other opioid will last for somewhere between 5 or 10 days. And the taper, as with many other aspects of our treatment here at Harmony, we try and individualize. So we know that not everybody's the same. And so that's part of my initial conference with them when they get here and choose to use buprenorphine, seeing if they've had a particular experience with it before and what they might choose as a duration of treatment. And again, as I said, using extended buprenorphine with a provider outside of Harmony after their discharge is a very, very individualized program. So we believe that addiction and the recovery from it may well be a lifelong process for people. Addiction, as we know, lives primarily in the primitive brain. It tends to knock out conversation between the grown-up part of the brain. People come to use their substances regularly and regard them as very pleasurable, and that that effect is etched deeply into the hippocampus, where we believe memory is kept. And so when times are hard for people, they know how to feel better rather quickly. So for that reason, I said that addiction tends to be ever present and infinitely patient. So, yeah, thanks for your attention to this. And now we will move on to questions or whichever part comes next.
Thank you, Dr. Reevely. So this back to building hope and building the program. So I talked initially a little bit about the staff survey, stakeholder survey, getting buy-in from staff and others, and our outcomes. And I wanted to just circle back on that after Dr. Reevely talked about how we use the M in MAT and how we incorporate that and how we look at that from a medical philosophy, treatment philosophy standpoint. And just to get back to our data, we did see after we implemented the HOPE program, a significant decrease in the against staff advice discharges among our opiate clients. So, and it leveled out was still higher than other clients with other use disorders, but it was closer approximately. And we also redid the Suboxone survey that I mentioned in 2018, and it really flipped. You know, it's kind of the law of threes, that there were 30% that didn't know about it, and 30% that were in favor and 30% that were against. And when we got back, it was really about 2/3 that were in favor, and the rest of them, there was a small percentage of people who still disagreed with some of it. And then there were still some staff that needed a little bit more training. And we have a facility that involves a lot of staff that aren't really versed in the treatment components. And so we continue to do education for all our staff to help them understand why we use medications in general, and why we use this, and why this is a topic at all of discussion among the treatment team. So, so I talked about sorry about that pop-up. I talked about the components of HOPE and how we try to really support the clients in all of their needs. And Dr. Reevely talked about how we support clients from the acute withdrawal period into the post-acute withdrawal period and ongoing. The HOPE group was something that was a unique and a really important part of the HOPE program, and it was the first piece that we implemented. So we did that before we really expanded our use of buprenorphine much, and that has continued to this day. And the HOPE group has become very, very popular at Harmony. In fact, there were people, some of our clients who were using substances other than opiates wanted to join the group, and we had a discussion about that. People were saying, well, I still feel, you know, I'm a cocaine addict and I feel like I'm misunderstood in my group, and can I go to this HOPE group? And so we had a conversation about that. We also had a conversation about alumni coming back to the group, and we actually do now offer, we give people a follow-up piece of paper that just says you can follow up with me and invite me back when I've been sober for 3 months, so I can come back. We haven't had anyone come back yet, but some people do say that they want to at some point make it back up and join HOPE group from an alumni perspective, which we think would be really valuable. So we're really excited about the HOPE group component of it, because we've had lots of our staff sit in on the group just to see what it's all about and see how it's run and why it seems to be so popular. And so when we originally designed it, we did look at the Core 12 curriculum from Hazelden Betty Ford and see how they ran their opiate support groups. We also wanted to promote the group with staff, so that's where we did the shadowing. We've had people from all departments in the facility who have shadowed the group at times. We wanted to create a structure that was a little bit different from some of our other programming. So all our therapy groups are limited to 12 clients, but this is some of our specialty groups are not as long as 75 minutes, and we didn't have many at that time. Have many groups that were mixed gender, all genders. So Harmony has treatment programming that provides specific services to people who identify as women and people who identify as men. And this we thought was an important piece of the puzzle that should involve everybody. Plus the numbers of clients would be pretty small if we did a group for women, female identifying and male identifying clients. But this was in our program, this was kind of different. And so the clients really liked that for various reasons. And so we also had to address the co-ed issue in the group, but it provided a really interesting dynamic and a really realistic dynamic that, you know, these are people are going to be exposed to people of all genders when they're in AA meetings, and can we help them to speak as openly as they feel safe and provide a container for that while they're still in treatment. So safety was a really important part of this, and confidentiality. We wanted this to be a group where what happened in this group stayed in this group and didn't necessarily have to be discussed outside unless an individual person wanted to discuss what they brought up in Hope Group. And that was something that provided an additional level of safety. So for the most part, the counselors who run the group, one of them is a lead counselor and would have known a number of the clients from their own groups, but one of the other counselors is a part-time counselor and does our therapeutic outings, among some other things like assessments. And so he was different. And so it was unique to have that combination of counselors, and clients really seemed to open up there to feel like this was something different. The process was basically a check-in, a combination of psychoeducation and process and check-out. So there was a kind of mindfulness component to really bring people to be present in the room. There was often a brief piece of psychoeducation that might be provided around opiate use disorders or recovery or Narcan. And then it was largely process, what was coming up for people. And along the way, we were very flexible, kind of basically expecting that we would need to revise it, and we would discover things along the way, because this was something different to have a group that is specifically geared to clients who meet criteria for specific disorders. So we expected revision and discoveries along the way. This is a handout that we give to the group, and we've actually used some of this then in our other groups because of the success of Hope Group. Basically, the gist of this is that we wanted to create a kind, respectful, open, safe environment. And one of the things we wanted to be aware of is triggers and this is true in any group, but it was something that seemed to come up a lot, that people would say, you know, I felt triggered by the group today. And we wanted them to speak up about that in the group. We also wanted to say, even though this is a specialty group around a specific substance, we all have our own experience with it. And so in a way, it says in there that we're all experts. So we're all experts of our own experience. And we really want to speak about our own experience and share that with each other and see how we can connect on what we're experiencing in treatment and in recovery. So as I mentioned, the group evolved, and as did the whole program at Harmony, coping with triggers coming up in group, as I mentioned, the balance of skills and process. Dr. Reevely and our nurse practitioners sometimes come in and talk about Narcan and provide some real specific guidance along for prevention of overdose. And one of the best things, along with the Hope Group, that really came out of this whole process was the interdisciplinary MAT team meetings. And that's what we call a meeting when anyone is considering, or the treatment team is considering, using as an extension of buprenorphine or extended buprenorphine for a client, that we bring everyone together again. We have lots of multidisciplinary team meetings, but these are kind of unique because we bring the client in, we have representation from medical staff, nursing, case management, counseling, sometimes a mental health person that might be working on a specialty mental health issue with the person. And sometimes we bring in the family member, either on the phone or in person. And we really want, if the family member or the referent, like a person is going back to another treatment center or a sober living home that's important to them, we want to include all of those people in this decision and really empower the client around what's important to them to make the right decision. There's also, we realized things that came up for people that, for example, financial, the expense of buprenorphine and other MAT products, that was something that had to be seriously considered for a lot of people. Sometimes the family they were going back to disagreed with the idea that the person was still going to be on an opiate. And so we had to provide some family education and support in those meetings. And then community considerations. This is getting better, but one of the things we really saw was that, especially with sober living programs, there weren't a lot of sober living programs, at least in Colorado, that allowed a client to continue taking buprenorphine. So that was a real struggle. If someone said, I'm going back to this area in Colorado, and there's the sober living that I want to go to doesn't accept buprenorphine. What am I going to do? And so that was something that we wanted. That's why we have the case manager there to really help with, let's look at the community the person's going back to, and let's make sure we're setting them out for success in whatever the decision is. So the decision about whether to use anti-craving medication such as Vivitrol or naltrexone, or to use an anti-craving medication such as buprenorphine, was really done as a team, empowering the client to help them make the right decision for them. And finally here, as I mentioned, I'm a person in long-term recovery, and so I had to go through a change myself, and I know a lot of our staff did, on understanding MAT, particularly using buprenorphine. And we don't use methadone, but we do use buprenorphine. And so understanding what that means long-term and what the person is also going to experience in recovery meetings. And in some recovery meetings, it kind of depends on the area, it depends on rural versus urban, it depends on AA versus NA, but in a number of 12-step meetings still, there's a bias against using people who are using buprenorphine. And so this was something we wanted to prepare people for, that they may get some of these messages. And these are things that are talked about in the HOPE groups and among the team and the clients and the families. So for example, you're trading one addiction for another. We wanted people to be prepared with an answer for this, that, well, I may be physically dependent on something, but the buprenorphine is being carefully managed by a medical provider and it's much less dangerous. There are often messages like, that's not a drug, that's a drug, not a medication. It can be abused. So really, there are lots of people in recovery who take medications, such as there's people who take benzodiazepines as prescribed, stimulants as prescribed, and technically medications are an outside issue in 12-step programs. So we tried to empower clients along those lines. And actually, Hazel and Betty Ford has a really good handout on what is a drug and what is a medication. That is really, those concepts are really helpful to people in understanding that. And it's similar to, we realized that back when antidepressants were first being used in 12-step programs, are saying you're not in recovery if you're taking Prozac. So this is different, but it's also kind of a similar thing. You're not in recovery, or you can't have a spiritual awakening on buprenorphine. Trying to help the clients understand that recovery really should be defined by themselves and their sponsor and their doctor and their therapist, and that spiritual awakenings come in many forms. who is to say, just there are a lot of strong opinions sometimes that you can't have, awakenings or major personality changes if you're on this medication, but there are also stories of people who absolutely have. So we really try to help people understand that rigid definitions of recovery can be pretty dangerous. We actually had one client who in the Hope group said something like once, well, I'd rather be on buprenorphine than dead. And I thought, well, you can't really say it any better than that. If they're gonna experience stigma or they're gonna experience difficulties being on this medication, but they know that this is something that is right for them because of the chronicity of their use and the severity, then that was a pretty appropriate statement. So now we want to go to questions. And Christy, I think you were gonna.
Yes.
It
Looks like, let's see. We have a question here. It says, what exactly is the abuse potential of buprenorphine despite the ceiling effect you mentioned earlier?
Yeah, I can address that. So I think that to start off with, when we make the decision as a team to start someone on buprenorphine here and then launch them out into the world, we work very, very hard at establishing, as I would with any medication, the minimal effective dose. So we want to send them out on the smallest dose that keeps them from having cravings, keeps them from drug seeking, and keeps them from having withdrawal signs and symptoms. Now, and then in that process, we also understand that it's easy to be comfortable inside the treatment bubble. And so we often take into account and sometimes increase the dose by a couple milligrams as they're about to launch back into life. Now, what is the abuse potential? Again, the pharmacodynamics, kinetics of buprenorphine are such that, as we saw in the graph, you can take more than 16 or 20 milligrams, but you're not going to get any more significant effect, be that euphoria or anything else. So I would say that is the main reason that buprenorphine is used on an outpatient basis and is much safer than the alternative, which would be methadone. And of course, we know that methadone is very tightly controlled, and clients have to go in and be witnessed taking their dose until they've been a good citizen in the program for a while, and then they can have take-home doses. But so the abuse potential would be that someone, and it mostly swirls around the issue of diversion. So if someone, again, has more buprenorphine prescribed than they really need, then selling it to others who may use it for various nefarious purposes, often simply to tide them over if they run out of their opioid of choice, is a concern. So, but the abuse of Suboxone or any buprenorphine product is much less than would be the potential for a full opioid agonist. But that's a great question. Thank you.
Perfect. Thank you. As I am waiting to see if anybody else has any other questions, I'm just going to roll through a few things. Just a reminder, we do record all of our webinars. So again, if you are interested in the slide deck or the audio recording, you can email me. I did put my email in the chat box a little earlier. And for those of you who are interested in our next webinar on August 28th, we do have Robin Kleisler with Resolution Peak Counseling talking about the impact of technology on mental health and recovery. So please look out for that registration email as it will be going out at the end of the week next week. So when you receive your survey today, please be sure to include your suggestions or topic ideas that you think you might be of interest to us, and we'll do our best to address those. And it looks like I do not have any more questions for today.
So, Christy, can I go back to one little point that Dr. Peters made?
You absolutely can.
On her last slide, it says the possible messages and responses, and the one that we all hear a lot, of course, is that you're trading one addiction for another. And I think part of the response to this is understanding the difference between addiction and a substance dependence. So when I use the term addiction, I use substance dependence, certainly, regardless of the substance, but I think of all the biopsychosocial and spiritual consequences of drug use. So my answer to that is yes, indeed. That person is going to have a physical dependency on buprenorphine should they continue with it for a period of time, and they will need to be tapered off very slowly at the end of that treatment time. But I will trade a single drug dependency for all the terrible consequences of addiction any day.
Okay. All right. Dr. Peters, Dr. Reevely, we want to thank you so much for this webinar. It was really informative, and know that you both have very busy schedules, and just so grateful you took the time to share this with us. And as there are no other questions, we're going to go ahead and wish everybody a good afternoon. And on behalf of Harmony Foundation, thank you so much for participating in our webinar series. We hope to see you again next month. Thanks again.
Thanks, everyone.
Thanks, everyone.